So down one goes and take the slide.
Great. Good morning, everyone, again. So today I'm going to talk about the mind-body regulations and cardiac arrhythmias, where modern science meets ancient practices. I mean, it's kind of a quirky talk, but again, I think arrhythmology is a science that I think has a lot to do with the mind, and then the rest of the systems that regulates it. And so this sort of interests me a lot, and we've been kind of doing some exciting work in this area, and I would like to share some of what we have done. These are my disclosures. Obviously, there is nothing I can disclose about it except that I'm pretty excited and interested about this particular topic. So today we'll understand the pathophysiology of the cardiac arrhythmias as it is relevant to the mind-body interactions, and then we'll try to explore some of these mind-body practices like yoga being an example of what could be done. I mean, it's only one of the forms of the mind-body interventions that we've taken up as a model. And then what are the future trends of alternative medicine care as it pertains to cardiac arrhythmias. So with this, I would like to quote William Harvey, who described, this is probably the first documented evidence of mind-body interactions, where he talked about the engine of emotion by saying, every affection of the mind that is attended with either pain or pleasure, hope or fear, is the cause of an agitation whose influence extends to the heart. A strong man who, having received an injury and affront from one more powerful than himself, and upon whom he could not have his revenge, was so overcome with hatred and spite and passion, which he had communicated to no one, that at last he fell into a strange distemper, suffering from extreme oppression and pain of the heart and breath. It's sort of a very poetic, very literate in its expression. So even though descriptions of the heart-mind connections have been going on since the onset of the human civilization, but the scientific work that went into exploring the mind-body connections is probably 200-300 years old through our studies through the anatomic and physiologic effects of the central nervous system and the autonomic nervous system. So what exactly is mind-body connection? So when I tried to put this talk together, I actually asked myself, so what exactly is mind-body connection? I couldn't quite explain it in a straightforward fashion. I couldn't really put it down together in 2 lines. So I Googled it. There is not really an exact definition for mind-body connection. There is all this descriptive, touchy-feely, emotional description of what it means nobody understands. So if you really cut it down, it probably comes from the word psyche and soma, which is psychosomatic, which represents the mind and body. And then it also refers to the connections between the body and the mind. And in a sense, it is based on the principle that the nature of the mind is reflected in the state of the body. So NCAM actually took it a little further, which is the National Center for Complementary and Alternative Medicine, by saying that these are practices that focus on the interactions from the brain, mind, body, and behavior with the intent to use the mind to affect physical functioning and promote health. So that's sort of the comprehensive statement that describes the mind-body interactions in its entirety. So before we go into that, I think it's probably important to understand the model of the biopsychosocial model. I think this probably is the best theory or a model that can explain the mind-body interactions in a much global way. And it positions the role of the biological factors and the psychological factors and the social factors that come together in the human functioning in the context of the disease. This is quite in contrast with the reductionist biomedical model, which has completely relied on the presence of a pathogen or an injury or a developmental abnormality to explain the disease process. So this whole discussion is essentially a philosophical argument between the biopsychosocial model and the biomedical model. So the next question that comes up would be, can this be extended to the empirical exploration and clinical application in the medical world? So if you trace back the roots of this whole mind-body exploration, it probably dates back to 5000 BC, as it was described in the Vedas and the Upanishads of the ancient Indian civilizations, and some of the ancient Chinese medicines as dating back to 2600 BC, the Greek medicine, and then as recently as 200 BC by the treatise of Patanjali's Hatha Yoga Pratipika talks about mind-body connections and interactions. And then I think over the years in different civilizations and different countries, I think this whole concept has evolved to become a few things. Until in 1976, excuse me, George Engel probably elegantly put together this whole concept of biopsychosocial model. So before we go into the next step, I think it's important to understand how exactly does it control? How exactly does it happen? I think that's where the concept of chakras, I think, is probably relevant to this whole talk. If people who are kind of connected to yoga, have done yoga, would understand that chakras are these wheels or vortices of energy that have been described to be present in the human body. Different philosophies believe that there are different number of chakras, but again, the popular one is the Sapta chakra, which is 7 chakras that are present from top of the head to the bottom of the body. As you see it in here, the top one is called the crown chakra, or the Sahasrara chakra, which is considered to be the consciousness and above. The third eye is the brow chakra, is basically your mind, your midbrain. The throat chakra is your cervical. Heart is the thoracic. Solar plexus is your lumbar, and sacral chakra is what it is. And then the base of the root chakra. This is kind of an interesting description of forces that guide the activities of the human body in a very elegant fashion. I mean, I'm actually very impressed to see that somebody could actually come up with a description of this a few thousand years ago of what translates to this, right? The 20th century cardiac autonomics can be simplified into what you have is the hypothalamic autonomic center, and then you have the brainstem, the tractus nucleus solitarius, you have the sympathetic outflow, the parasympathetic outflow, the spinal cord, and its varied connections through several receptors into and basically takes it to the cardiac autonomics. So if we superimpose these two concepts, I think this is what we're going to get into. It's pretty complicated. I'm sorry that I could not make this slide any better than this. So as I talked earlier, so this is the first chakra, or the Sahasrara chakra, which is the supra-consciousness. This is your third eye as it pertains to the midbrain and the medulla, and then you have the cervical, thoracic, lumbar, sacral, and the last chakra. I think this is kind of the analogy that we can bring together to understand the workings of the mind and body as a continuum. So the biopsychosocial model is not without criticism. I mean, a lot of this, as I described to you early on, is very touchy-feely, foo-foo, is what a lot of people call it. But is there a reason why people think that it is to be the case? I mean, I think the biggest opponent of this whole BPS model is McLaren. He's a psychiatrist who strongly opposes this. I think more so, it is more of a problem in the psychiatric world than in the other areas, where he opposes by saying that since the collapse of the 19th century models of the so-called psychoanalysis, biologisms, and behaviorism, psychiatrists have been in search of a model that successfully could integrate the psyche and the soma. So keen has been their search that they embrace the so-called biopsychosocial model without ever bothering to check its details. If at any time over the last 3 decades they had done so, they would have found it had none. This would have forced them into the embarrassing position of having to acknowledge that modern psychiatry is operating in a theoretical vacuum. It's a pretty powerful statement to really bring out the true deficiencies in the model. But I think the scientific world has done a few things to really disprove this to some degree. I think it's still correct, but I think there is a lot of work that is going on that is going to stretch this realm into newer areas. I think this is where we need to learn a few things about a few new things that have happened in the heart-brain axis. As it is put in Anatomic Consideration, this is an elegant review article published by one of our speakers, Dr. Sam Asirvatham, in Cardiology Reviews, where he talks about the cardiac autonomics and arrhythmias as it pertains to it. So it's important to understand that there is the extrinsic autonomic nervous segment, and there is an intrinsic cardiac autonomic nervous segment, and then you have the cardiac substrate in itself. The extrinsic autonomic nervous system, as you see here, consists of the inputs that you get from the brain and through the spine into the sympathetic and the parasympathetic supplies to the heart. And the intrinsic cardiac autonomic network is constituted by the ganglia that are surrounding the heart and the related structures. I will not go into the details of that. These are some of the microscopic and histoimmunological work that really proves the presence of autonomic innervation in its complicated manifestation. And some of these things actually have been proven as early as 1973. I was pretty impressed to see that the American Heart Journal actually had a publication at the time of a case report where a yogic was trying to do a controlled manipulation of his heartbeat. Another nice review article by Taggart et al. It's a very nice paper published in 2010. Really summarizes the interactions of the brain and the autonomic nervous system of the heart and its manifestations as it pertains to coronary ischemia, as well as the electrophysiologic changes that could be manifest changes in action potential durations or refractoriness of the myocardium, as well as the dispersion of the relaxation phases, initiation of the early after depolarization and so forth, and subsequent effects on calcium, potassium channels. So what is the evidence behind the effects of the higher brain function and cardiac electrophysiology in arrhythmogenesis? There is resounding evidence to prove that effects on brain can lead to ST depressions or elevations, T wave changes, QT prolongations, and it can cause arrhythmias, supraventricular as well as ventricular, and it can result in myocardial damage, as it is seen with myocytolysis and patchy necrosis around the nerve endings, causing myocardial stunning, and then the increased sympathetic activity as it is expressed by increased catecholamine release as well as heart rate variability and so forth. So we've learned that stimulation of sympathetic nerves or stellate ganglia can result in decreased VF thresholds and thereby the change in ventricular repolarization, and that in turn can induce ventricular fibrillation. And similarly, we learned about the baroreflex sensitivities, the cardiac reflexes, and then the sympathetic nerve damage in models of myocardial infarctions and the nerve sprouting, and the heterogeneity of nerve sprouting itself can explain the onset of a lot of these arrhythmias. And we also learned about the enhanced sympathetic activity is a precursor for VF and VT in sudden cardiac arrest. This is being proven beyond discussion. So, and then we also understand that the heart in itself is a dynamic interactive substrate. It changes continuously and evolves continuously, partly reflecting the fluctuations in the autonomic tone in the rest of the body. And we have discussed this earlier, that when we have enough proof to say that the increased sympathetic tone can alter the automaticity after depolarizations, ventricular and atrial action potential durations, and refractoriness, and action potential restitution, conduction velocity, and dispersion of repolarization. What all of this means is it changes enough things in the electrophysiologic milieu that it can be arrhythmogenic. That's all what it means. A lot of complicated words, isn't it? But Dr. Jackman can actually throw a lot more light on this better than I on some of these exciting things as it pertains to atrial fibrillation. And we also have noted that in some case examples of inherited channelopathies that these patients are very sensitive to autonomic stimulation. And the net effect obviously depends on the type of channelopathy you have and the type of channel and the current that is involved. And as it is very clearly documented, increasing sympathetic activity is pro-arrhythmic in long QT1, long QT2 patients, and increased parasympathetic activity is pro-arrhythmic in Brugada and long QT syndromes. All of this clearly point to the role of cardiac autonomics. And then there is the theory of lateralization, as it was seen in the brain PET scans, and then a report in JAMA actually talks very elegantly about this. So lateralization of cerebral activity during emotional stress may stimulate the heart asymmetrically and produce areas of non-homogeneous repolarization, and thereby creates a milieu for electrical instability and thereby facilitate cardiac arrhythmias. It's kind of a very elegant theory that is actually very well proven by PET scans. There is a difference in the way your brain perfuses and the brain activity changes. And then we also known that heart rate variability suffers in patients who have ICD shocks. Patients with poor heart rate variability are more prone for ICD therapy, suggesting that they are at risk for more VT and VR. So having this background information, I think, in the EP world, the entire physiologic syncopal spectrum, atrial fibrillation and ventricular fibrillation probably fits in with this mind-body connection the most. And that's where, if we go to atrial fibrillation, we know that atrial fibrillation triggers from the pulmonary venous, non-pulmonary venous sources play an important role. And this is a model that shows how the triggered activity initiates AFib. I think this is a simplistic depiction of the initiation of atrial fibrillation. And then we understand how the paroxysmal arrhythmia evolves to become more persistent and permanent forms, and the role of stress, inflammation, and myocardial remodeling all factor into this. And there is resounding evidence to show that emotional stress and atrial fibrillation are big triggers for this. Anybody who deals with atrial fibrillation, which I bet all of us here would understand the emotional aspects of atrial fibrillation, and that we deal with, that is manifest in our patients on a day-to-day basis. And then there is very clear-cut evidence that stimulation of the autonomic ganglia and combined parasympathetic and sympathetic nerve stimulation can result in spontaneous activity in most of these cells and result in atrial fibrillation. And this is another nice slide that was also taken from Dr. Asirvathim's review paper that clearly shows the role of the autonomic innervation of the heart around the pulmonary veins and the role they play at that level in initiating atrial fibrillation. There is another nice paper that actually studied the variations in the autonomic tone before the onset of paroxysmal atrial fibrillation. What's clearly known is LF, low frequency component, refers to sympathetic drive, HF, which is high frequency, refers to the parasympathetic drive. So the LF-HF ratio is one of the variables that we use to determine the autonomic balance in the body, which is basically the sympatho-vagal balance. As you see here, before the onset of atrial fibrillation, just about 10 minutes before, there is an increased surge of the sympathetic tone, raising the LF-HF ratio, with a sudden withdrawal of the sympathetic tone and sudden onset increase in the parasympathetic tone. So this is kind of a spontaneous variation in the cardiac autonomic tone that would precede the initiation of arrhythmias. And the next one is everybody's favorite, the syncope phenomena, right? The neurocardiogenic syncope. Why does neurocardiogenic syncope happen? I think simplistically, you can say that whether you believe in the theory of evolution or not, at least in the state of Kansas, you're not supposed to. When the human bodies, the heart's location went up when we were four-legged animals versus two-legged human beings, obviously there is a shift in your overall gravity. So if you really go with the gravitational pulling of the blood in the legs upon standing, there is obviously decreased venous return, and in some of these folks, there is exaggerated sympathetic activation that triggers the C fibers at the base of the heart, and thereby there is a paradoxical sympathetic withdrawal and exaggerated parasympathetic activation, which results in low heartbeat as well as lower blood pressures that causes syncope. I think this is again an oversimplification of a complex physiologic process that we don't really have a good hang on. And obviously, this is a classic example of asystole during a head-up tilt table study. How does heart rate variability play a role in this? I think it is very clear that the LF-HF ratio just before they pass out goes down, and as you see, as they pass out, the parasympathetic activity becomes very predominant. So there is resounding evidence to prove that mind has a great control on that. then what is the whole situation about VF and VT, the sudden cardiac arrest? There are several facts that have been proven at multiple levels. There are several anecdotal case reports. There are national disasters during the hurricanes and earthquakes and so forth. There is an increased sudden cardiac death incidence. And then experimental models in animals. And then human observations as it pertains to stress-induced coronary microvascular constrictions and ischemia, stress tests, T-wave alternance, and then the role of emotional stress in channelopathies. And then, in fact, there is a socioeconomic influence too. Again, nicely putting together the biopsychosocial model of the pathophysiology of VFRS. Why should we consider yoga as a model here? I think they are simpler to do. They're inexpensive. There is large amounts of clinical data that is readily available on the use of yoga for several disease conditions. And then we clearly have evidence that impacts the autonomic tone. So this is a nice study from a German group that clearly shows that yoga positively affects the heart rate variability by changing the sympathovagal balance. And I think we could use that concept to fit right into the mind-body regulation as a treatment, as an intervention for atrial fibrillation. So this is a little study from Cleveland Clinic from years ago. This is hypnosis, effects of hypnosis on post-operative atrial fibrillation. They're very clearly shown a statistical difference, and people undergoing hypnosis therapy before surgery actually have a much better improved outcomes in terms of AFib. And then the role of biofeedback in atrial fibrillation. In fact, some of these patients were able to control their heart rates. This paper goes as back as 1973. So effects of biofeedback on controlling ventricular rates and so forth. And so there are lots of papers that have come out between, in the last decade to decade and a half, since that last criticism from McLaren to really disprove that it is all bogus. I think there is some science behind it, and I think the human eyes cannot see what's not in front of them, but again, I think we only fail to see what is actually happening inside our body, and a lot needs to be explored. And based on that, we undertook this exciting project of studying the effect of yoga on the arrhythmia burden and quality of life in patients with paroxysmal atrial fibrillation. We presented this at the National American College of Cardiology this year. We had 49 patients out of 52 consecutive symptomatic paroxysmal AFib patients that were enrolled in it. All of them had a 3-month period of self-control, followed by 3 months of intervention with yoga. And then we assessed their SF-36 quality of life scores, anxiety, depression scores, and then the number of atrial fibrillation episodes as documented by the non-looping event recorders during the study and the control phases. So we used a combination of pranayama, which is the breathing exercises, dhyana, which is meditation and relaxation, and asanas. And these were a long list of asanas that we used. Most of these are very commonly used in most of the yoga-based studies. This is the conventional BKS Iyengar form of yoga. And the baseline characteristics were no different from your average atrial fibrillation patients. And this is what we found. We found there was a significant reduction in the number of symptomatic episodes without AFib as well as symptomatic episodes with AFib. We all know that patients of atrial fibrillation always have the symptoms of palpitations. I think it's almost a memory phenomena that haunts them day in, day out. There are several episodes that they think they're having AFib. You put them on a monitor, there's nothing going on. So that really shows you the phantom effect of what these arrhythmic episodes can cause. A graphic representation of the same. What was more exciting was the depression and anxiety scores went down dramatically. I mean, the number of phone calls my nurses received went down like that. That's always an exciting thing, right? When your patients don't call you that their heart is racing, it's taking off. And then their SF-36 scores actually have improved very nicely. I mean, in the areas of physical functioning, general health, sense of vitality, social functioning, and mental health, we did find some significant improvements with the yoga regimen. So what we concluded from this is that it doesn't cure AFib, but it does improve the symptoms, arrhythmia burden, anxiety, and depression scores, and physical functioning, general health, and other markers of quality of life. our hypothesis, our working hypothesis behind this is that yoga has pleiotropic effects. It has effects on the central nervous system. It changes the lateralization of emotion and thereby the autonomic manifestations. And it changes the autonomic tone, and it also decreases systemic inflammation and thereby oxidative stress and so forth, and thereby resulting in overall a reduction in the number of arrhythmia episodes. And we are excited to see that this actually can be extended to the other things. I think we have a very complicated treatment regimen for neurocardiogenic syncope. I was excited to see that there were 5 patients that we put on yoga. In fact, some of these people even had implantable loop recorders as part of their workup. And at least 3 of the 5 have such dramatic results that after 2 months after going through the yoga program, their neurocardiogenic episodes completely disappeared. I mean, if you interrogated their ILRs, there would be asystolic episodes like 4 or 5 times a week in the previous few months. And then once they picked onto it and kind of became active practitioners of those, then their number of episodes significantly went down. This encouraged us to come up with another hypothesis. I think if you increase the modulation of the heart rate variability and the sympathetic and the parasympathetic tones, you may be able to attenuate that initial trigger, which is this exaggerated sympathetic tone, which in turn can result in that paradoxical release of increased vagal tone. I think that's where yoga can probably fit in and help the patients to reduce these episodes. And that has led to the Sync Yoga study. We're going to kickstart here in the next few days, and I'm actively looking for more sites from around the country to be part of this. And then I was also pretty excited to see a lot of work that is being done on ventricular arrhythmias. There was 2 case series in 2006 that reported a 50% reduction in the number of PVCs. This absolutely makes sense, right? You decrease the sympathetic drive, which in turn is the trigger in most of these patients' PVCs. You can probably decrease the number of PVCs that happen in these people. There is another study that was presented as recently as the Heart Rhythm Society in May that showed the role of yoga in decreasing the symptoms of anxiety and depression in patients with ICDs. There is another group that is looking at the effect of yoga and the reduction of number of ICD shocks. I think that will be very exciting to see what the results would be in those patients. So with that, I'm going to stop and thank you all to share a few funny slides. For those who have not seen these, I thought these were hilarious. One of my friends sent me these because he makes fun of me as a yoga man, and he finds every and any reason to make fun of me. So that's yoga reading for you. Thank you very much.
Thank you, DJ. It's a wonderful lecture. It tries to show the ancient people are not so ancient, you know. It brings their hearts into more investigating in more scientific fashion. Thanks for doing that. We'll ask the questions later on at the end of the session, so please save those questions for the speakers. I will now introduce Dr. Gary Haas from Ohio State. He's a heart failure researcher and the director of a cardiac transplant program at Ohio State. And he would talk about the pressure sensors and all the exciting things. You know that heart failure has become one of the major problems in this country and elsewhere in the world. And we need better tools to monitor and intervene earlier. And Dr. Haas will explain to you, to us, all the new things and gadgets that we can implant and so forth to identify heart failure early and make it easier to manage them. Thank you. Welcome.
Where's the point? The top one is the pointer. The right one is slide forward. This one is slide backwards. Thank you very much. It's a pleasure to be able to talk to you today, or this morning, about